Thank you, Ben. Good afternoon, everyone. At the onset, I would like to thank the organizers for giving me a chance to present here. I will be talking about how we have now incorporated AI in the treatment of stroke patients. Okay, so if you look at the evolution of the management of acute strokes, prior to the year 1990, there was nothing much which was done. A patient would come in with stroke or stroke-like symptoms. He would undergo a scan. It would be classified as ischemic or hemorrhagic. They would then move on to secondary prevention. The etiology or the cause of the stroke would be looked for, but there was no real treatment for acute ischemic strokes. This changed in 1996 with the introduction of a drug known as IV TPA or tissue plasminogen activator. This was given to patients within 3 hours of stroke onset. Then in the early 2000s, they managed to increase the window period to 4.5 hours for this kind of treatment, that is the IV TPA. In 2010, there was a dramatic change in the management of acute ischemic stroke. This is when endovascular treatment came in. Endovascular treatment basically essentially means that we go in and retrieve the clot which is blocking the vessel. This was initially for 4.5 hours from onset to 6 hours from onset. Then 2018 was a game changer because with newer technology and newer imaging modalities, we were actually able to take patients for mechanical thrombectomies even up to 24 hours. Present day, we are now using AI to help us select which patients should be taken for mechanical thrombectomies, should be receive IV TPA, or which should be conservatively managed. So IV thrombolysis, it's basically recombinant tissue plasminogen, and simply put, it dissolves the blood clot. The eligibility criteria is a patient presenting within 4.5 hours from the onset of the stroke. There's an extensive checklist which has to be gone through before the patient receives the medication. The benefits are well proven, and patients who receive it do very, very well. The basic problem here is patients generally do not reach us within the first 4.5 hours. There are a lot of delays by the time they reach the emergency room. The checklist which has to be gone through is quite extensive. There's also a fear factor in physicians to use this drug because they feel it may cause bleeding or conversion of an ischemic stroke into a hemorrhagic stroke. But yes, the patients who do fit the criteria and do receive the medication have been shown to do really well. Endovascular treatment started off in 2010. It has undergone a revolution, and the devices which are used, the technology which is available is far better than what we had in 2010. So the patient selection criteria would be based on a CT scan, a CT angiogram, and the time window. The CT scan would rule out whether there is a hemorrhage. The CT angiogram would be able to guide us to show us which blood vessel is blocked. And the clinical evidence initially we had from Mr. Clean and Escape and Extend IA trial, which demonstrated clear benefit of mechanical thrombectomy in patients with ischemic strokes. We have now, as I said, been able to extend the window period up to 24 hours with the newer trials using selected imaging criteria. So when you talk of strokes, one of the common classifications of what has caused it is what is called as a TOS criteria. So the most common ones would be a large artery occlusion or cardioembolic strokes. These are basically where pieces of plaque break off and go and block a blood vessel within the brain. These are called large vessel occlusions, and even cardioembolic is where you have a clot which goes from the heart into the brain and blocks one of the vessels. So when we put a patient to either mechanical thrombectomy or IV thrombolysis, we reassess the patient at 3 months to see how he has done. We use a scoring known as a modified Rankin scale. This basically shows us whether the patient is disabled and how disabled he is. We consider a good outcome if the patient scores 2 or less on the scoring system. Score of 6 is basically a patient has not survived the stroke. And as I said, scores of 2 or less are considered to be good. So what are the imaging modalities we use in acute strokes? The first one would be a non-contrast CT scan. This would be to rule out hemorrhage. We then moved on to do CT angiogram in patients to rule out large vessel occlusions. We now do CT perfusions. CT perfusion is basically a scan which will show us how much viable tissue is left if the patient was to undergo a thrombectomy. And currently we are using AI again to help us decide which patients enter the cath lab and which don't. So in this scan, it is a plain CT scan. This was done in the early years. We look for signs to suggest whether there is a bleed or not. Some of the other radiological signs were what we call as a hyperdense MCS sign, or where the red arrow is that blood vessel occurring very prominent. This would suggest that there is a large vessel occlusion. We've now moved on to what is known as CT perfusion. CT perfusion shows us what is the penumbra, which is the viable tissue, and what is the core, or which is the dead part of the brain, which cannot be salvaged. So basically what you're seeing on these maps is the pink area, that is the core of the stroke. That area is unlikely to be salvageable, but the surrounding green area, that is the penumbra, which if we go in, we can reverse some of the damage. This is a CT angiogram. It's done on a CT machine. It shows us all of the blood vessels supplying the brain and can guide us which vessel is blocked and the access we have to use to enter and open that vessel. So why does all of this matter? Why are we trying to improve the treatment of acute ischemic strokes and make it faster? Stroke is the leading cause of death and disability worldwide. It has a high global incidence with a significant morbidity and mortality. Substantial disability-adjusted life years are affected. Time-sensitive interventions, whether it be thrombolysis or endovascular treatment, are critical. Time is brain. This is one of the most important concepts. So for every minute that there's a delay, 1.9 million neurons are lost. Time loss, so for every 10-minute delay in initiating clot-busting treatment, you're losing 2 months of healthy life. If you improve your parameters by treating the patient 15 minutes earlier, the odds of a good recovery are increased by 10%. And if you are able to intervene in the first 60 minutes, the outcomes are far better than if they were delayed. So the current challenges before we incorporated AI into our treatment plan was variability in imaging interpretation. What this basically means, if you show a CT scan to 3 different radiologists, it is most likely that all of them are not going to concur with the same reading. A transfer delays to specialized centers, so these are centers where mechanical thrombectomies can be done, and also where you have advanced imaging modalities for strokes. Resource limitations in smaller hospitals where the CT angiograms can be done, where the CT perfusions can be done. And disparity in access to advanced stroke care is also one of the current challenges. So AI in stroke, basically the core concepts of AI are machine learning, deep learning. Machine learning is where the computer looks at data without actually being programmed to do it. Deep learning is another type of machine learning, but it creates algorithms to analyze the data. And natural language processing is where the machine learns how to understand what is being told to it. Simply, it's like voice to text. And robotics. Robotics is one of the things which I think Dr. Scott also spoke about. This is coming in stroke in a big way, especially in places where there's no interventionist available 24/7. What happens is there's a stroke robot which is in the cath lab. The access is given by one of the local physicians there. And the machine is actually operated remotely, sometimes even from a different country. So what are the AI for stroke core applications? So automated imaging. So it's basically as simple as the patient reaches the triagist confirms that the patient is showing symptoms of a stroke. The patient is shifted to the CT suite. A CT with CT angiogram and perfusion is done, and you get the reports. You get to know which vessel is occluded. You get to know the perfusion or the core penumbra. It also gives you outcome predictions, workflow prioritization in the sense that everybody who's involved in thrombectomies would be activated. And it also has a role in telestroke, which we use with other islands as well. So the common softwares which are used are Rapid and the other ones like IS-AI. The current one which we use at Health City is Rapid AI. So before the introduction of AI about a year and a half ago, what would normally happen is a stroke patient would arrive in our emergency room. He would undergo a CT with a CT angiogram or an MRI with an MRI angiogram. We would then have to wait for the radiology report. It would usually take about 30 minutes before decision whether to thrombolize the patient or whether he's a candidate for mechanical thrombectomy was actually taken. This would be because either the radiologist is busy, he's not available on site, the patient has come in the middle of the night, and hence there were a lot of delays in deciding what kind of treatment the patient would benefit from. After AI, our stroke protocol has pretty much become very simple. The patient reaches the ER, he has symptoms suggestive of a stroke, he's shifted straight away to the CT suite. We don't wait for any kind of creatinine, or any of the blood reports. We do a CT with a CT angiogram with a perfusion. We get immediate reports showing us which vessel is occluded, what needs to be done, and there's no difference between operators. And this has actually been shown to have a 95% sensitivity in accuracy. So even if I or the rest of the team is not physically in the hospital, this is the kind of information we get on our mobile phone. So the first thing which we will come to know is, does the patient have a bleed? So the CT, the first image is basically that there is a bleed, so then we step back because then we cannot thrombolize the patient. It goes down a different pathway. The next thing which it gives us is what is called as an aspect score. An aspect score is the scoring system we use to find out how much of the brain is damaged. It's a score from 0 to 10, where 10 is normal, and for every area when infarct is seen or damage is seen, 1 is minus. It then, and this being the most important, shows us which vessel is blocked. So you can see this one on the left side, the vessel is occluded. So it will let us know that, okay, this is the target vessel, this is where you need to go in, and this is where you need to intervene. It then also gives us the perfusion. The perfusion shows us the penumbra, or how much of the brain is damaged and how much is viable. And then it then decides whether the patient is a candidate for thrombectomy or not, and it sends out a message to everyone who's involved, be it me, the interventionist, the cath lab technician, the cath lab nurse, the ICU doctor. Everybody is basically informed, and all of this takes less than 5 minutes to process, and the messages come directly to our phone and to our emails. So this also helps us to rule out intracranial bleeds. It is able to detect small bleeds. Why this is important is because, let's say we are told the CT scan is normal, the angiogram is also normal, the patient is still showing symptoms of a stroke. We would then decide to thrombolize the patient using an IV thrombolytic. Now, if it is a very small bleed and it is missed, that can be a catastrophe, but this kind of software actually detects even small bleeds and lets us know this patient is not a candidate for thrombolysis. Using this kind of technology, we have actually improved our CTA to groin time by 26%. What that basically means is from the time the CT angiogram and CT perfusion is done to the time the patient is on the cath lab table and we have punctured the vessel, there's an improvement in 26%. The accuracy is 95% for large vessel occlusions, and improved aspect scoring also. Aspect scoring was another problem, so if you show it again to 3 different radiologists, you are bound to get 3 different aspect scores for what the patient is having. And this is round-the-clock coverage. I mean, you don't need the radiologist to be there. You immediately get all of the information on your phone, and you know how to proceed. So currently, the imaging protocols would be a non-contrast CT with a CT angiogram and a CT perfusion. This is the cornerstone. The perfusion CT helps quantify the salvageable brain tissue. Rapid AI improves the speed and accuracy, supports decision-making. Integrated imaging and AI optimizes patient outcomes. So these are the parameters which we look at when in strokes. So you have door to needle time, which benchmark is 60 minutes, 45 minutes. Go to puncture time, which these are the target times. And this is the scoring which we use after a patient has undergone a mechanical thrombectomy. So what that basically means is when we try and open the vessel, if there's complete perfusion, it would be a grade 3, which is something we are aiming for. If we are unsuccessful and not managed to open the vessel, that would be a grade 0. So grade 2B and 3 is what we aim for in patients we take into the cath lab. So these are the Health City metrics which we've actually managed to achieve over the last year and a half. So door to needle time for IV TPA, we're actually managing to do it in 20 minutes. We do this because the patient comes, shifted straight CT angiogram. The stroke nurse is present in the CT suite with the thrombolytic agent. We've now moved on to tenecteplase rather than TPA. So we just give it as a bolus and the thrombolysis is done. Door to puncture time, so if it is a candidate for thrombectomy, we are able to get the patient into the cath lab in 45 minutes. Again, the reason we're able to do this is because when the alert goes, the cath lab team is activated, they know the cath lab should be vacant and that there is a potential stroke. And in most of our patients, we have achieved TICI 2B scores, so we've achieved a good perfusion post-thrombectomy. So post-thrombolysis care is equally important to just doing the thrombectomy and the IV. This is because there is a risk of complications. When you open a blood vessel, there's always a risk of what we call as a reperfusion bleed. There's a chance that the blood vessel may reocclude. There may be swelling within the brain because of the stroke. So when we do a procedure, the patient is then admitted into the ICU, and this optimizes outcomes and supports recovery. So post-thrombolysis monitoring would be on a stroke bed in the ICU. We initially monitor the vitals every 15 minutes for 2 hours, then 30 minutes for 6 hours, and hourly for the next 16 hours. We target a BP of less than 180 by 105. We do regular neuro checks, that would be an NIHS stroke score and a GCS regularly. 24 hours, at 24 hours, we'd repeat a CT scan just to rule out that there is no reperfusion bleed or bleeding which has occurred. And after this, the patient would be started on antiplatelets or anticoagulants. Lab and supportive care, so we would monitor his complete blood counts, coagulation profile, creatinine. If the patient develops a fever, antipyretics if more than 37.5. Prevention of aspiration, initially we keep it NPO until the patient undergoes a swallow screen. And early DVT prophylaxis, either mechanical, if hemorrhage is detected, or if needed, we can switch to oral anticoagulants as well. The management of a stroke is a multidisciplinary thing. It involves the neurologist, the stroke specialist, the interventionist, and also we need a lot of support from physical therapists, occupational therapists, and speech and language therapists. And also stroke coordinator, which monitors all of this and tracks outcomes of stroke patients. So the ideal scenario, which unfortunately in Cayman we are not able to do, is after you have done a thrombectomy or thrombolized the patient should transition to what is known as a stroke ward or rehab ward, where they undergo round-the-clock therapy. Unfortunately, in Cayman, there is no round-the-clock inpatient intensive rehab available. For those who can and the insurance does support it, we shift them overseas for inpatient rehab. We then move on to identify what has caused the stroke. Is it a condition like atrial fibrillation, carotid stenosis? Based on that, we start the patient on secondary prevention. Then family education and counseling is also very important as to what the family can expect going forward. So close monitoring is crucial after any kind of reperfusion therapy, whether it's IV thrombolysis, then monitoring the blood pressure, neuro observation, and a team-based approach is absolutely essential in the management of strokes. So currently, this is a stroke protocol which is followed. The patient identifies that he's having signs and symptoms of a stroke. 911 is called. The patient is put into an ambulance, and he's either taken to a stroke-ready hospital or hospital which is a primary center. Once he reaches the primary center, the patient undergoes a CAT scan. If there is no bleed identified and the patient has symptoms of a stroke, He would receive the thrombolytic treatment and then be shifted to a hospital where a thrombectomy can be done if the scan suggests that the patient needs that. If he reaches a stroke-ready hospital, then of course he would undergo the scan with the rapid protocol, the perfusion scan, and if needed, taken into the cath lab for a thrombectomy. So what are the barriers in stroke care? They basically start with pre-hospital. This is the most important, is that where the public are not aware of the signs and symptoms of a stroke. So a lot of public awareness has to be done. We do this with regular campaigns, such as the FAST campaign or Be Fast campaign, where we try and educate the public as to what the signs and symptoms of a stroke are. Sometimes the EMS also triages the patient wrong if the stroke symptoms are minor. Hospital delays. So the EMS would have picked up it's a stroke, but for some reason that notification does not reach the triage. This is important because if the triage is informed earlier that we have a stroke patient en route, they can inform the neurologist, inform the CT room, and everybody who's involved that there is a stroke patient coming. So everything is ready and there are no delays. Sometimes stroke patients may present with non-specific symptoms like blurring of vision. Sometimes it can be missed. Sometimes could be dizziness as well. And of course, emergency departments, which could be understaffed or overwhelmed. And delays in neuroimaging, whether it's a CT scan or CT angiogram or CT perfusion. So all this can be eliminated if there is a pre-notification of a stroke patient reaching the hospital. In-hospital workflow issues. So slow activation of the stroke team, that is again, the symptoms have not been identified or missed. Delay in lab results. So this is important, especially if you want to thrombolize the patient with an IV agent, because what we are seeing now is a lot of the patients are on oral anticoagulants, and because of that, there may be contraindications to giving IV thrombolysis. Lack of standardized protocols or drills. So it is very, very important, and even in our institute, we keep doing drills so people remember what needs to be done when, and we look for ways to improve. We also try and audit our time stamps and try and work on ways to improve that. Poor interdisciplinary coordination, so that would be between the emergency department, not informing the neuro team, etc. Radiology now, to an extent, after we've integrated AI in it, they're sort of less involved, so that's not much of an issue. Imaging and decision-making, again, this has improved since we have integrated AI into our workflow. The CT perfusion, the MRI is not operator-dependent. We straight away get results on our phone and know which patients to take up. Some hospitals don't have access to these kind of tools. Inexperience in interpreting perfusion maps. So again, some of the hospitals do have the capability to do a perfusion, but then again, you need experience in interpreting those perfusion screens. So post-acute barriers, delay in rehab initiation. This, as I said, is something we significantly see in Cayman. We have no inpatient rehab. We have to send most of the patients overseas. That's those whose insurance will permit. A poor transition to outpatient care. So this could be because either the primary care physician has not been informed as to what happened, what caused the stroke. Limited patient education. And we see this quite often, and it's quite surprising. The patient who have had a stroke goes home, thinks the medications are only for 1 month, and at the end of 1 month stops everything. Gaps in secondary prevention. So that would be monitoring that the patient is compliant with his anticoagulants, his blood pressure monitoring, his diabetes, that kind of thing. So what are the impacts of these barriers? There's increased mortality, increased disability, lower access to thrombolysis and thrombectomies, and increased readmission and economic burden. This particularly now because we are seeing strokes in younger patients as well. So overcoming these barriers, the first part would be public education. So we do radio shows, we do we give talks in companies where we try and educate the patients, we try and educate people how to spot the symptoms of stroke. The most simple one being the anagram Be Fast. where if the patient develops symptoms which affects his balance, his eye movements, his face becomes asymmetric, or when you ask him to lift his arm drops, speech becomes slurred or incomprehensible, then that would be time to call 911. Protocol-based workflows is the most important, and they improve outcomes a lot in the management of acute stroke. Telestroke and rapid AI tools. So we do provide in our institute telestroke services to some of the other hospitals in the Caribbean. We are trying to incorporate their CT images into our rapid AI, which we've not managed to do till now. So it would obviously give us better answers and faster. So a regional stroke network and pre-arranged transfer agreements. So like for certain hospitals in the Caribbean, if there is a stroke, we would be notified. The air ambulance would go there. The patient would be shifted to Cayman. And policy support for 24/7 stroke-ready hospitals. So this would be more of an administrative thing where the administrators are willing to support and provide the necessary infrastructure to improve outcomes. So that is about strokes. We now move on to another type of stroke, which is a hemorrhagic stroke, and where AI is also playing a role. So that would be brain aneurysms. So broadly speaking, we divide brain aneurysms into two types. They would be bled aneurysms and unbled aneurysm. If a patient presents to us with a bled aneurysm, the classic history would be a thunderclap headache or the worst headache they've ever experienced in their life. Those patients need to be taken up for treatment as soon as possible. The treatment may be endovascular, where we go in and put in coils, or it's sometimes surgical, where they open and put a clip across the aneurysm. The other set of aneurysms are unbled aneurysms. These are aneurysms which are incidentally picked up on imaging, be it a CT or an MRI, which was done for headaches or migraines. Now, the issue which happens here is every aneurysm which is unbled does not need to be treated. It needs to meet certain specific criteria before they're considered candidates for treatment. So there's a size criteria, there's a location criteria, there's a criteria where we look for weak spots on the aneurysms which may predispose them to ruptures. So the way we use AI is AI algorithms are trained to find these brain aneurysms on routine CT angiograms and MR angiograms. We see this often. So a patient would have undergone an MRI and an MRA. It would have been reported as normal. A couple of months or maybe a year down the line, the patient comes with a subarachnoid bleed. The aneurysm is seen. When you go back retrospectively, you can see the aneurysm in that scan, again, because hindsight is always 20/20. But this AI software basically actually detects these small aneurysms or blister bled aneurysms much more efficiently than humans do. It also helps us predict which of these are at risk for rupture, thereby helping us better decide which patient should be taken up for treatment. Machine learning models can also be based on to identify patterns for risks that they are for rupture. Hemodynamic analysis that would show us the blood flow into and out of the aneurysm, again to quantify whether these unruptured aneurysms should be treated or not. If the patient is decided to be taken up for treatment, it can help us choose what kind of treatment, whether we take the patient for what we call as a flow diverter stenting, whether we take them for endovascular devices, which we place within the aneurysm, or whether we take the patient up for just coiling or clipping. Post-treatment, so let's say the patient has had a bled aneurysm or an unbled aneurysm, we've treated it. These patients need to be followed up. What we are looking for is the aneurysm completely gone? And the second thing is, because this patient had one aneurysm, there's always a risk that they may develop another aneurysm, so which is why we keep doing screening scans just to make sure that there's nothing else seen. So these are just a couple of cases which we've done. The first one would be a stroke. 42-year-old female, very healthy, no medical comorbidities. She got up at 5 a.m. and went to the restroom, came back and slumped down on the floor. She had a complete left-sided weakness. She was taken to Georgetown Hospital. A CT brain was done where they recognized that there was a hyperdense MCS sign. This would be considered a wake-up stroke because we don't know if the patient woke up with the weakness or whether it happened at that time because the history was not very, very clear. Hence, they did not thrombolize her and they shifted her to us for further management. Clinically, she was conscious, she was obeying commands, she had a right-sided gaze preference, which is something we commonly see in patients of a large vessel occlusion. They tend to look to the side where the stroke is. She had a dense left-sided hemiplegia, and her NIHS score was 14. We immediately put her into the CT with a CT angiogram. So this is the CT angiogram. This would be the left side of the brain. This is the right side of the brain. This was the message we got on the app saying that there's a large vessel occlusion detected and that this patient needs to be taken up for a mechanical thrombectomy. We took her up and this is what we found. There was a blockage. This is the stent retriever which we put into the vessel. Initially, it was a bit of a disaster because the whole blood vessel occluded for some reason. We then managed to go back in and open the vessel. And the patient had a fantastic recovery. She actually walked home within 2 days, leaving the hospital. So this second patient, he was a 71-year-old male. He was air ambulance from Cayman BRAC. Last seen normal at around 11:30 a.m. He was found with the right side. She was found with a right-sided weakness and was aphasic. She was taken to Faith Hospital, then put in the air ambulance and brought to Grand Cayman. CT brain, again left MCS stroke with a left M1 occlusion, and she was referred to us for further management. She arrived at 8 p.m. So now the stroke onset was 11:30 a.m. She arrived to us at 8 p.m. So this is now outside all traditional window periods. Again, she was conscious. Aphasic means she was not able to speak at all. She had a gaze preference to one side, so she was looking towards a stroke. Densely hemiplegic on the right side. She had a pretty high NIHS score of 18. Again, put her into the scan. This is what the rapid AI told us, that she does have a large vessel occlusion. And the perfusion map showed that even in spite of this occlusion, there was a significant penumbra which was viable and that she should be taken up for a mechanical thrombectomy. So we took her up into the cath lab. This was the vessel completely occluded on the right side. And this you can see after we have recanalized the vessel. She did well, but as I said, because we did not have any kind of inpatient rehab, we had to send her overseas. But the patient is doing really well. She is walking, speaking, and I believe she's back home in the BRAC now. This was a young lady, 45-year-old female. She was recently detected to be hypertensive, had no other risk factors. She developed the worst headache of her life. Now, this headache is called a thunderclap. So it's not like your classical migraine or migraine-type headache, which slowly builds up and reaches its peak. This one is bang. It is a 10 on 10 headache from the onset. And that's why we call it as a thunderclap headache. She was taken to HSA, CT brain was done, and it showed what is known as a diffuse SAH or subarachnoid bleed. And she was referred to us for further management. So clinically, she was conscious, photophobic or very, very sensitive to light. She had a full score GCS and she was moving all 4 limbs. This was the CAT scan which was done. So the whitish area which you're seeing here, that is the bleeding which has happened within the brain tissue, which is classical of a subarachnoid hemorrhage. Then this is the CT angiogram which was done, which showed us that she has an aneurysm in this blood vessel known as the ACOM. It also showed us the access which we had to reach till the aneurysm. So this is in the cath lab. That is the aneurysm you can see there. This is an image which we call as a road map, which basically, it's a live image and we can see our catheter moving within the blood vessel until we reach the aneurysm. So this, what you're seeing, is the microcatheter. Our target is to reach till there. And this is after we have put the coils into the aneurysm, and the aneurysm is completely healed. These procedures are done under general anesthesia, and then the patient is woken up. They are at risk for things like vasospasm or spasming of the blood vessels. She did really well, and I think within 4 to 5 days went back home. And even at follow-up with the repeated scans, there's no growth seen in the size of her aneurysm. This is the fourth case, 56-year-old female. She had a background of hypertension, which was poorly controlled. Again, she was at work and developed the worst headache of her life. A thunderclap headache, was taken to the hospital. CT brain was done, which showed a subarachnoid bleed, and she was referred to us for further management. Clinically, she was not doing, she was more drowsy than the previous patient, but she was arousable. She was moving all 4 limbs and had a full score GCS. So this was the CT angiogram which we did for her. And what you can see here is this large sac-like structure. That was the aneurysm she had. And we immediately took her up into the cath lab. And what you can see is the balloon. This whole thing was the aneurysm. It's known as a dissecting aneurysm, where the vessel sort of tears apart and the blood goes into a wrong track and causes this kind of aneurysm to form. Immediately she was taken up for coiling under general anesthesia. So what you can see here is there were 2 lobes to the aneurysm. We managed to enter 1 lobe, coil it, but we were not able to enter into the second lobe. This is commonly seen in these kind of dissecting aneurysms because we are not able to go through the part of the vessel which has been damaged. So in this kind of case, what we then decided to do is put what is known as a flow diverter stent. Flow diverter stent, simply put, is it's a mesh-like structure which diverts the flow of blood away from the aneurysm into the normal vessel. Normally, in a bled aneurysm, we try and not put this kind of device because the patient has to be put on long-term blood thinners. So it's sort of a contradiction. You have a patient who's had a bleed and you're putting him on blood thinners, so it's a difficult situation. So which is why we would first try and do coiling, and then if needed at a later date, put in a flow diverter stent. But in this case, we were not able to get into the second part of the aneurysm, so we had to put in the flow diverter stent. So we put in the stent. This is after 1 stent. There was some slowing in the reduction. Yes, on this one you can see, this is the part which we have coiled, and I don't know if you can appreciate this mesh here. That is the flow diverter stent which we put in. So there was some reduction, but the aneurysm was still filling. So we then had to go in and put in a second stent, and after that, this is the result we got, where the aneurysm was completely excluded from circulation, and this patient is also doing really, really well. So basically, in conclusion, time is brain is the most important thing. We need to get the patient to a stroke-ready hospital. We need the imaging to be done fast. We need the imaging to be interpreted. Patients who need a mechanical thrombectomy need to be taken to the cath lab as soon as possible. We are seeing very good outcomes in patients who reach us early. But now, because of this AI which we have integrated into the workflow, we are also seeing good outcomes in patients who are taking late. And more importantly, we are seeing less complications like reperfusion bleeds, because those candidates who would be at a higher risk are not being taken up for any kind of therapy and are being conservatively managed. Be fast is something which we need to inform the public. We need to reinforce it with our patients. Clinics need to put it up as signage. So everyone is aware of the signs and symptoms of a stroke. We still see patients reaching the triage with a chest pain, which may be completely non-specific, but we also see patients who would go to sleep saying their left side felt weak before they went to bed, and then they come the next day with a full-blown stroke. So public education is still something we need to work on. Effective stroke treatment is available, and AI helps us to choose patients who will benefit from mechanical thrombectomies or whether they would benefit from TPA. They are now using this kind of software to even extend the window period for IV thrombolysis. So I'd like to conclude with a video. World Stroke Day is, I believe, on October 29th. And our marketing department is making an effort to sort of increase awareness amongst the public regarding the signs and symptoms of a stroke and how important it is to reach a hospital early so that the patient will improve.
What's your emergency?
Thank you.